So the last speaker of this session doesn't really need much introduction for this audience. Professor Yang-Pan-Chyr was Dean of the School of Medicine, NTU, and also President. And of course, among his achievement, of course, everybody knows that he's really done this really courageous and ambitious low-dose CT test in Taiwan, and that has a really tremendous impact on the local medical practice as well as influence in the international approach now. So we'll let Dr. Yang to give an update on the screening process.
Thank you, Chair, for your kind introduction. Let's switch the gear to the lung cancer. Today, I'm trying to talk about the lung cancer screening in Asia. So this is the key content that I will talk about. Asia actually has the highest disease burden of lung cancer in the world. And non-smoking lung cancer, actually, it is a totally different disease and prevalent in Asia. And then the molecular pathogenesis of non-smoking lung cancer. What are the risk factors and feasibility of lung cancer screening? You want to focus on non-smokers. So the lung cancer screening using low-dose CT, what are the current status in Asia, and how we implement nationwide low-dose CT screening in Taiwan. So actually, we all know that tobacco-related lung cancer is the #1 cause of cancer mortality worldwide. But if you look at the non-smoking lung cancer, actually, it ranks 5th in the all cancer mortality, even higher than colon cancer. So non-smoking lung cancer actually may accounts for more than 30% of lung cancer mortality worldwide. And Asia has the highest disease burden of lung cancer in the world. 63% of lung cancer occur in Asia, and 63% of lung cancer mortality occur in Asia. So this is the smoking prevalence of lung cancer mortality in Asia. You can see lung cancer is #1 cause of cancer mortality both in men and in women. But if you look at the smoking prevalence, it's quite different from the Western country, different from the United States and Europe. Most of the lung cancer patients in men and women, they are associated with smoking. But in Asia, especially in East Asia, the smoking prevalence is very low, especially in women. You can see Taiwan, China, Singapore, South Korea, all the same. So I use this is the data from South Korea. You can see lung cancer is the #1 cause of cancer mortality in men and in women in Korea. High smoking prevalence in men, very low smoking prevalence in women. But the #1 cause of cancer mortality in Korea is not breast cancer. In women, it's not breast cancer, it's not colon cancer, it is lung cancer. And exactly the same picture in Taiwan. So this is the fact. Lung cancer is the leading cause of cancer mortality in men and women. Smoking is more than non-smokers, higher than smokers. Very high female to male ratio. Usually lung cancer is disease of men, but actually in Taiwan, it's very close that the lung cancer in women, actually the incidence is very high. We have very high female to male ratio. And never smoker in women, lung cancer is nearly more than 94%. You can see that in lung cancer patients, nearly 2/3 of them, they did not have smoking history. Only 1/3 of them, they are smokers. So, and then more than 50% of them, they diagnosed in stage 4 disease. So that's why the outcome of lung cancer is so poor in Taiwan. And the smoking actually contributes very low. In males, only around 27%, and women is only about 5%. So this is the driver mutation lung cancer. We saw that actually the East and West are quite different. We write a review article in Annual Review of Medicine. At that time, we clearly demonstrate that actually in Eastern Asia, more than nearly 50% of them, they have EGFR mutation. But in Caucasian, it's only around 20 to 25%. And KRAS, smoking-related KRAS mutation is higher. But in Eastern Asian, KRAS mutation is around 10 to 12%. So actually, the EGFR mutation is associated with the Eastern Asian especially the Chinese acidity. We did a prospective study. At that time, we showed that it is acidity play a very important role. Chinese, Thai, Malay, Kin all have very high EGFR mutation, but Indian, the EGFR mutation is relatively low. And even in heavy smokers, they still have high EGFR mutation, though that means that the EGFR mutation is associated with non-smoker, but it is also associated with the Eastern Asian acidity. So we did a lot of study. We now find that what are the risk factors for the non-smoking lung cancer? Family history play a very important role. Some genetic susceptibility, including some SNPs and endogenous alphabet signature, and also the female gender in Asia is the high risk. What are the exogenous risk factors? Air pollution may play a very important role. As you can see here in Eastern Asia, we have relatively high PM2.5 exposure. And we did a lot of study to find out actually instance of the lung cancer in Taiwan is associated with the exposure to the PM2.5, exposure to the air pollution. This is not unique in Eastern Asia or in Taiwan. Actually, this is a study done in British Columbia. They tried to examine the non-smoking lung cancer and their association with the air pollution. They found that compared to the ever smoker patient, lung cancer with never smokers have very strong association with being female, Asian, and having the air pollution, especially the PM2.5 exposure, especially in women that Asian, they have a higher odds ratio up to 6.48. That means that Eastern Asian female seems to be more susceptible to the carcinogenesis by the air pollution in terms of lung cancer. So let's look at the lung cancer in non-smoker nature history. Usually it grows very, very slowly. You can see here, takes 10 years, became this size. And after surgery shows that it is a mucinous adenocarcinoma. So usually it grows very, very slowly. And another one, a ground-glass nodule, takes around 10 years to grow this size, but develop widespread metastasis. This is a non-smoker EGFR mutant. If we have a strategy to take this nodule out, probably we can cure the patient. Actually, the patient develop widespread metastasis, even with the very aggressive treatment with the target therapy and chemotherapy, and the patient still died 2 years after diagnosis. Sometimes non-smoker is not so benign. This is a small nodule. Look at this nodule, less than 2 centimeters in diameter. When they diagnosis lung cancer, the lady already had widespread bone metastasis, a stage 4 disease. 2 centimeters in diameter lung nodule in non-smoking lung cancer is still late. So familial clustering is very important phenomenon in non-smoking lung cancer. You can see here, this is a big family tree. Mother had lung cancer. 4 daughters all confirmed to have lung adenocarcinoma. They are all non-smokers. The only son is a heavy smoker. He did not have lung cancer yet. But even these 4 daughters confirmed to have lung cancer detected by screening, but 3 of them already passed away. So familial clustering is a very unique phenomenon in non-smoking lung cancer. And another very unique finding is that multicentric. Sometimes the non-smoking lung cancer comes with multiple ground-glass nodule bilateral lung. 18% of them in Taiwan study. This patient, upper lobe and nodule, the lower lobe and nodule, all confirmed to have lung adenocarcinoma. It seems that the field carcinogenesis may play a very important role in non-smoking lung cancer. So, and if a patient had multiple lung nodule confirmed to have lung cancer, do you think they are coming from the same clone? No, they are coming from maybe different clone. We did a single cell RNA-seq show that even the patient had 2 lung nodule, the driver mutation are different. So we want to know why non-smoking lung patients develop lung cancer. So we started the Cancer Moonshot program. We focus on lung cancer because we have so high non-smoking related lung cancer and high EGFR mutation, relatively early onset. So in this proteogenomic study, we showed that some endogenous factor play a very important role, and the exogenous factor, including the air pollution, the nitropolysaccharide aromatic hydrocarbon, and nitrosamine, they are associated with the risk of lung cancer. The carcinogen actually concentrate in chromosome 7p. Why chromosome 7p is so important, I'll tell you later. You can see here the nitropolysaccharide aromatic hydrocarbon and nitrosamine, which are commonly seen in air pollution. The genetic signature actually concentrate in the chromosome 7p. And the chromosome 7p actually is the EGFR mutation located. So that means that the air pollution may associate with the risk of the occurrence of the EGFR driver mutation. We further work on the proteogenomic pathway for non-smokers and demonstrate that in those non-smokers, air pollution, the associated nitrosamine, and especially the polysaccharide aromatic hydrocarbons, they can activate the PD-L1 signaling and also iron signaling. And this environmental carcinogen actually associated with the outcome of the EGFR mutant lung cancer. And we also demonstrate that even they are early stage disease, we can identify the proteomic biomarker that can help us to stratify the risk of the stage 1 disease. That means that even the stage 1 disease is relatively had good outcome, but in some patients, actually, they are high risk, they progress early. So in those patients, probably they need adjuvant treatment to prevent the cancer recurrence. And the air pollution is associated with PM2.5 study from Charles London demonstrate that the EGFR mutation has higher correlation with the exposure to PM2.5. They use the cohort from Korea and Taiwan. They demonstrate that the EGFR mutation is associated with the exposure to EGFR associated with PM2.5 exposure. So we write the review article to demonstrate that the PM2.5 actually can induce the inflammation, increase the IL-1 beta, IL-18 and others, and go through the, they can induce the DNA damage, increase oxidative stress, and go through the area hydrocarbon receptor and activate the oncogene, especially the EGFR driver tumor progression. We also use the multi-omic study for early lung cancer progression in non-smokers. Is it linear? Probably we don't think so. We take the very early lung cancer, the adenoma, AAH, adenoma hyperplasia, carcinoma in situ, and minimally invasive lung cancer, the invasive lung cancer, and use multi-omics to show that actually in some drivers, especially the EGFR, is increased with the increased the invasiveness of lung cancer and P53 too, but other drivers like the BRAF, they did not follow this same pattern. It seems that the BRAF in early lung cancer relatively slow progression compared to the EGFR driving tumors. So we use that to demonstrate that we are able to develop the expression signature using these early lung cancer studies. And this, we identify some additional biomarkers that can help us to stratify the risk of stage 1 disease progression using the very early lung cancer study cohort. So why non-smoking subject develop lung cancer? There are some SNPs associated with the risks of non-smoking lung cancer. Totally 25 of them, they can help us to develop a polygenic risk score, identify the high-risk subject that can benefit from low-dose screening. And family history has been very important. This is a very important study. 1,102 participants with family history of lung cancer. We follow for 10 years. Cumulative lung cancer detection rate up to 4.5%, especially those with multiple family members who had lung cancer. The risk is up to 7.7%. It's more prominent in non-smokers compared to these smokers. And Asian females seems to have higher risk. Asian able smoker does not have significant difference compared to the non-smokers, but it is quite different from non-Asian. And Asian female seems to have higher risk. So that's why we start the talent study focused on non-smokers with family history of lung cancer. We now finish this study. Totally, we recruit 12,011, half of them with family history of lung cancer. This low-dose CD lung cancer screening demonstrates that we have very high lung cancer detection rate in the first round, even higher than NLST and Nelson. 96.5% of them are stage 0 to 1. That means that 96.5% of them, they are potentially curable. And family risk increased the risk of lung cancer. And it is very unique. We have relatively high ground-glass nodule. 1/3 of them still confirmed to have lung adenocarcinoma. And if you compare those with family history of lung cancer and those without, family history still increase the risk of lung cancer. And most of lung cancer actually detected in the first round. So the lung cancer detection rate rapidly slowed down, decrease. That means indicating that non-smoking lung cancer, they grow really very slowly. So that means that the screening interval can be just not, there's no need to do any low-dose CD screening, maybe every 2 years or every 3 years, depends on the risk of each individual. So we did the consensus of the low-dose CD screening in Asia, and we did a lot of conference, and this is the current status of lung cancer screening in Asia. I just want to point out that only 3 countries, that Korea, Japan, and Taiwan, they have national lung cancer screening program. What are the impact? These 3 countries had relatively high stage 1 disease and relatively low stage 4 disease. So that's why the 5-year survival is much better compared to other Asian countries. You can see here in Malaysia, nearly 85% of the lung cancer patients are diagnosed in stage 4 disease, so the outcome is very poor. So we convinced the government to start low-dose CT screening program in 2022, July. We are aiming to double the stage 1 disease and 5-year survival by 2030s. The program focused on smokers, now reduced to 20 pack years up to 2024. And another one would be family history of lung cancer, especially non-smoker or light smokers. In women, we took the screener relatively younger, 5 years younger. This is a detection rate. You can see nearly more than 200,000 screened. The detection rate is up to 1.3%. And you can see 82.4% of them are stage 0 to 1. In heavy smoker, the detection rate is only 0.8%. In those family history of lung cancer, the detection rate up to 1.7%, and nearly 89% of them stage 0 to 1. It is extremely useful for the women non-smoker can see the detection rate up to 1.8% compared to the heavy smoker men, the detection rate is only 0.8%. So before lung cancer screening, 50% stage 4 disease, and stage 4 disease outcome is very poor. Even after intensive treatment, still the survival, 5-year survival is less than 15%. And stage 1 disease only 30%. By low-dose CT screening, we increased the stage 1 disease from 30% to 74%, decreased the stage 4 disease from 50% to 7%. We estimate can reduce the lung cancer mortality by 53%. So we use AI to generate a virtual control model and compare those with family history of lung cancer and smokers. By low-dose CT screening, we are able to reduce lung cancer mortality 67% in those family history, many non-smokers. And in smokers, we can reduce 36% of lung cancer mortality. It's comparable with Nelson and LST. And Singapore follow Taiwan's talent study, start to screen the lung cancer patient, focus also on those family history of lung cancer, especially in non-smokers and smokers. The detection rate exactly the same. And we share our experience to international society, and we have a consensus in Asia, and we write an editorial to say that you cannot say no to non-smoker. You cannot say we don't need screening for non-smoker. It is not correct. And we present our result in many international meetings. This is in last year, 2024, discussion. Use our slides and to say that this is a slide she made, that American and Europe, they should follow Taiwan's strategy to screen the high-risk non-smokers. So this is the take-home message. Non-smoking lung cancer is a new emerging disease worldwide, especially in Asia. It's totally a different disease. Genetic and PM2.5 may associate with risk of lung cancer, and female and family history increase the risk of lung cancer. We need a different strategy for screening in Asia, and Taylor study confirmed that it is feasible. We are able to do that. We are fortunate to convince the government to start a low-dose CT screening program. It is now the very good model for the international society to follow to screen the lung cancer in non-smoker with risk factors. Thanks for your attention.
Thank you for that very exciting update. So it's open to the panels now. Go ahead.
Thank you very much, Professor Yang, for your excellent talk and a great contribution. I especially appreciate that you persuade the government to take your advice for cancer family history to receive LDCC that helps a lot of patients to be detected earlier. For HCC family history, they also have greater risk that has been described in many treatment guidelines. And our study indicates that antiviral treatment can decrease HCC from 15% in 10 years to below 2% in 10 years. But I proposed many times, but still fail. Can you give me advice to persuade the government and the senior staff?
Yeah, it is not easy, but it takes a lot of effort, not only me, a lot of our colleagues there, a lot of scientists there, and also the clinicians, they all to work together, try to give the evidence to the government and persuade them that we need to do the low-dose CT screening for that. If we really want to control lung cancer, you should do that. It takes a lot of effort.
Thank you.
Ren?
Yeah.
Thank you.
I have one question, it's nothing to do with the money, okay?
Okay.
First of all, is, I think a breast condensate, has been used for the asthma,
Yes.
as a screening. And I don't know whether you can use a breast condensate to screen the early lung cancer.
Yes, actually, we are trying to do that to correct the respiratory condensate and to use the ctDNA or the biomarkers, especially the inorganic volatile compound to see whether we are able to detect lung cancer, but seems that the result is not so promising so far. Xinjian, anything?
Yeah, Pan-Chyr, thank you so much. So yes, I think yesterday or the day before we discussed a little bit, what is the guideline after the low-dose CT scanning that that will constitute that you need to do more? You need to do biopsy or surgery. There was some discussion over surgery. Yeah.
Yes, actually, we have a guideline. I always persuade our surgical thoracic surgeon society. We have a guideline for that, but because usually the non-smoking lung cancer that grow very slowly, especially those pure ground-glass nodule. So no need to operate too early, but you need to have a radiomic to have that. Actually, we are now initiating a prospective study called CBER using the radiomics to stratify risk from the initial CT scan. And then we can stratify each individual, the screening interval, and we hope that, and also the radiomic can help us to identify those higher risk of invasive lung cancer. They should operate early. Usually, we hope that they follow the guideline. Usually, we hope that the patient operate around 1 to 1.5 centimeter. Don't operate the tumor too early, especially those with ground-glass nodule. Only if the ground-glass nodule increase in size or they are solid part in the ground-glass nodule, we suggest the patient to receive the thoracoscopic resection. And the biopsy may be not necessary because the thoracic resection is much more easier and less invasive. So the risk is very low. So sometimes we don't need the needle biopsy for the ground-glass nodule.
Great. One more question over there.
Great talk and congratulations. About 2 months ago, there was a paper in Nature looking at
Yes.
cancer from different countries. And 5% of the Taiwanese cohort has this AA Aristotle signature. What's your thought of that? I mean,
Yeah.
I was surprised what we described in kidney and lung and
Yes.
kidney and liver.
Yes,
And now
yes.
see that in the lung.
Initially, I thought that this signature, 马兜铃酸, I speak in Chinese, is commonly used as a herb in Chinese traditional medicine. Initially, we thought that probably it's only associated with kidney, renal cell carcinoma, and hepatocellular carcinoma. But in that paper, the tissue is coming from Xiongzhou, it's from Zhanghua. And that relatively high, the only signature is observed in Taiwan cohort. And we are trying to urge our scientists, especially work on the public health, start to look at the cohort, especially in the cancer moonshot and other cohort. We did not see that, but I think that is probably because of the depths within the initial signature does not come out. But we do think that probably Madolinsan may play a role.
So those are not metastatic cancer to the lung, I hope.
No, it's primary.
It's primary.
It's primary. It's primary.
All right, well, thank Dr. Yang and the other two speakers for the wonderful talks, and we conclude this particular session.